or whoever want to ask the question on page. Now, it's my privilege to introduce Dr. Mahendra Singh. He is the last speaker, but definitely one of the most important aspect of today's discussion. He is working as the additional professor in the Department of Community and Family Medicine at All India Institute of Medical Sciences, Rishikesh. His area of interest are community-based antimicrobial stewardship, public health management at peripheral and institutional level. He has got more than 75 publications and many awards from Rishikesh, Oxford, and UK coalition. Over to you, Dr. Mahendra, and I hope you will be on time and so that we can take some questions at the end.
Thank you, sir. I am audible, sir?
Exactly. You are.
Good evening to all.
And moving. Please go ahead.
Thank you, sir. So, I am sharing the experience or journey of AIIMS Rishikesh in area of pharmacist shop stewardship, which is the one of the important activity for antimicrobial stewardship. Next. We all know there are many stakeholders in area of antimicrobial stewardship, and pharmacist one of the key stakeholder in this area. They can play a very important role in antimicrobial stewardship. They ensure wisely and effective use of antibiotics, which is the very important for development of antimicrobial stewardship. They are key contributor to fight against antimicrobial resistance. And today I am presenting how AIIMS Rishikesh conducted various activity to develop this pharmacist stewardship to achieve ultimate goal of antimicrobial stewardship at AIIMS Rishikesh. Next. So AIIMS Rishikesh involved all key stakeholders from doctor to paramedical staff. Dr. Manish discussed how we involve all the key stakeholders in development of antimicrobial stewardship at AIIMS Rishikesh. And this one important key stakeholder is the pharmacist, who is the link between the patient and treating physician and play important role for prevention of antimicrobial resistance. And we all know this antimicrobial resistance awareness week, which is celebrated every year, 18 to 24 November at a world global level and also at AIIMS Rishikesh since 2018. And during this activity, we try to involve pharmacists from since 2018 to development of pharmacist stewardship at AIIMS Rishikesh to involve in various activity to achieve ultimate goal of this stewardship. Next. So these are the various activity under this pharmacist stewardship, which include visit to pharmacist shop to creating awareness, to conduction of the roundtable meeting with pharmacists, organization of the pharmacist stewardship workshop, and last year we also started the organization of quiz competition at baseline and endline level for these all pharmacists. Next. So one of our major activity under pharmacist stewardship to visit to pharmacist shop. And this activity we started during World Antimicrobial Week celebration, wow, from 2018. From 2018 to 2022, we started this activity on a small scale. We include, try to cover all the pharmacists which working in AIIMS Rishikesh Hospital and some pharmacies nearby AIIMS. But the last 2 years, 2023 and 2024, we expand this activity, and now we cover all the pharmacists who are nearby AIIMS and also pharmacist shop located in field practice area and cover the near PSC, CSC, district hospital pharmacy shop. So this 2023, one day, day 2 dedicated for visit to pharmacy shop. Next. And 2024, last year, WOW Celebration Week, we dedicated 3 days for this visit to pharmacy shop. 2 days exclusively dedicated for visit, and last day once again we reinforce whatever we message, whatever education, advocacy we given to these farmers. Once again we memorize, reinforce, and so they can continue use this education and advocacy in near future in development of antimicrobial stewardship. So next, we included all pharmacy shops in and around AIIMS Rishikesh, cover around 30 to 40 pharmacy shops in last year activity. Our team consists of SR, JR, and intern doctors. We created 5 to 6 such teams. Each team have a responsibility of 5 to 6 visit to 5 to 6 pharmacy shops. During this visit, our main goal to focus 5 key areas and to tell the pharmacist how they can support development of antimicrobial stewardship. To focus on these 5, don't provide antimicrobial without a prescription, encouraging best way to use antimicrobial, discuss self-medication with antimicrobial, monitor local pattern of the antimicrobial use, and motivating patient to take antimicrobial exactly as prescribed. And we also cover the this is the picture showing the our team visit to pharmacy shop, which consists SR, GR, or intern doctor. And key the pillar of these activity or future doctors, intern doctors, and they train and they deliver the message to all pharmacists to interact with them and tell them how they can prevent antimicrobial resistance development. Next. So these are the activity conducted in 2023 WOW celebration. Next. Next. And this is the 2024. Once again, every year we expand their service and cover more and more pharmacy shops. In 2024, we almost cover all the pharmacy shops located near and in Rishikesh area. Next. Next. Also, we focus on the cover. These all activities should be covered in the media, local newspaper. So it will be increase the awareness also in local people as well as in these pharmacists, healthcare workers who involved in these activity. Next. So we ensure the good media coverage during these activity. Next. Next. So second activity during this pharmacist stewardship, the conduction of round table meeting. Normally we conducted this activity at the last day of WOW celebration week, and we invite all the pharmacists which we already visited. Now our objective of this round table meeting, in-depth interaction with all these pharmacists, and also explain in more detail and formal discussion with them how we can prevent antibiotics, what are the difficulty to implementation of antimicrobial stewardship, what are the challenges, and we also discuss one case by scenario with them. Next. Next. And this is the general invitation to send to all farmers during this roundtable meeting. Next. So this is the one roundtable meeting we conducted in 2022 onwards, 2023 and 2024. Next. So, and last year we started the organization of pharmacy stewardship workshop, which we deliver the once against the key message and some case-based scenario and academic knowledge too. And also we focus, because in field practice area, PSC, CSC, in rural area, these are many times situation occur when pharmacists have to give the antibiotics to patients. So what are those situations? Our main purpose to avoid the antibiotic without doctor consultant, but there is some situation. So we explain through these workshops in what are those indications when they can prescribe if there is a emergency situation and there is no other option. Next. And we also focus in this workshop to aware about the provide knowledge about the what are the reserve antibiotic groups and how to save those reserve antibiotics, and uh, all these are covered in these workshops to main principal theme: educate, advocate, and act now. So this is the one of the activity which started we last year uh, in Wow Celebration Week. Next, next, next. And last year we started quiz competition, which covers the antimicrobial resistance, basic knowledge of antimicrobial stewardship. We assess the baseline knowledge during the first and second day of WOW week, and then whole WOW week we provide the intervention in the form of talk, visit, roundtable meeting, workshop, and now on the suggestion of our coordinator, Dr. Prasan Pardaki, once again we should assess their knowledge, how much improvement in their practice, and so at 6 months we again assess their knowledge. Next. Uh, Although this is only sample size was very less, as we included 16 pharmacists who working, but they are all working in different pharmacy shops, in campus, in hospital pharmacy shops, outside PSC field practice area. So the result is post intervention. We saw there is a improvement and significant improvement in their knowledge. Uh, 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 Not only individual, overall group improvement, on individual level improvement. So it is very increasing, and these such type of activity can improve antimicrobial stewardship. Or small and sustained effort can provide a good results. Next. So our take-home message: each hospital of India can create a pool of antimicrobial stewards pharmacists by involving them during World Antimicrobial Week celebration on the theme of educate, advocate, and act now. At least each hospital can educate and advocate surrounding local pharmacists towards antimicrobial resistance stewardship. These activities should not limit to only WOW celebration week. These activities should be conducted at regular interval to develop a sustainable atmosphere of antimicrobial resistance stewardship among farmers, because all farmers are the very key stakeholder to development of this stewardship. Thank you. Thank you very much.
Hello.
Yes, sir.
Excellent, Dr. Mahendra. This is one of the means what I have heard. Dr. Prasanna has already answered the questions from Dr. Bhaskar. Still, for others' benefit, let me ask it again. Are there any particular antibiotics which are not indicated for PAT? Dr. Prasanna.
Yes, sir. As I said, the guidelines say, because this is a new thing, the only 2019 the first guideline came, so there is no documentation about this. And but the softer points are there definitely. Few antimicrobials those who are giving like QID or 4-hourly. Suppose you are giving actually ampicillin or piperazine factor as a term. So those antibiotics who are giving more frequently, that is actually is less practicable in the periphery, and that is the only softer angles where it cannot relative contraindication we can like that. But otherwise, there is no particular antibiotic that cannot be given in the home with a one-day monitoring by the treating physician.
Perfect. Anybody else would like to ask anything? Dr. Sumit, are you there? Dr. Sumit? Okay, if he's not there, let me ask to any of the panelists. One of the case scenarios was shown. The patient was an ET. The ET aspirate showed Pseudomonas and the blood culture showed Acinetobacter. It's quite a common phenomenon over the years in institutes. Probably the treating team was treating Pseudomonas with meropenem and Acinetobacter with ampicillin and sulbactam. So how do you go ahead with treatment of Acinetobacter? I do not mean a colonizer or a commensal, but if you think it is a commensal, then how do you proceed with treatment of Acinetobacter? Dr. Prasanna, if you can like to answer, or anybody else, the pharmacology team. Dr. Manish, Dr. Mahendra, Dr.
Yes,
Bhupendra, anybody?
so for this, I discussed in one of my case scenarios also.
Yeah, that's why I brought it into picture.
Yes, sir. So it was like in ET aspirate, the Pseudomonas was intermediately resistant, sensitive to colistin, and as well as A. bomani also. And the patient was on meropenem, ampicillin, sulbactam, and clindamycin. So for Acinetobacter baumannii, what we did was we kept the ampicillin sulbactam, because sulbactam, it is the one of the beta lactamase inhibitor which has got efficacy against Acinetobacter baumannii. So that is why instead of giving or meropenem, we preferred giving the ampicillin sulbactam. And in addition to that, the duration of infusion, which was previously being given for 30 minutes, so that in duration was also advised to be a little longer, up to at least 3 hours, or 3 to 4 hours is that is a good time to have the accumulation of this particular drug. So that will be, sir, my suggestion, that ampicillin sulbactam was a preferred agent for this case.
Yeah, I do not have any question at this point of time. Any of the panelists would like to bring out any other take-home message? Yes,
Yeah, about this question of Pseudomonas plus Acinetobacter actually combined infection, regularly, many times we are coming across this situation. That time, the combination therapy, apart from the ampicillin sulbactam or isolatedly sulbactam, actually we are giving. Along with that, since the polymyxin, if it is intermediate sensitivity, definitely polymyxin actually we are adding. And patient is not improving. That point of time, we are thinking it is more of a biofilm formation, like the case was ET aspirate, or even if got with a prolonged hospitalization, what we are regularly seeing the ICU setup. In that, the minocycline we are adding here actually, and it has some better response to the patient. So with the minocycline, because the two major antibiotic class actually, which is good to the biofilm, like that usually develop in the prolonged hospitalization. One is definitely the quinolone group, but that usually resistance in our setup. So next is the minocycline group. And last is the rifampicin actually group, depending on the site of infection and whether it's a gram positive or gram negative. So in the gram negative, minocycline we are using, and we are getting a good response. And for the gram positive, definitely the rifampicin, but rarely I have used till now only 1 or 2 cases for especially the prosthetic or the valve involvement as a part of infective endocarditis, which is not being. We could not actually get some culture positivity, but since patient in the ICU and not responding, so that is the mainly the last armamentarium we use here as a rifampicin. But minocycline is a good option for the both the condition of Acinetobacter and Pseudomonas.
Perfect. Dr. Bhaskar, would you like to pitch in? Are you still there?
Yeah, Dr. Kadanga, good afternoon.
Yes, Dr. Sumit. I was
Yeah, actually,
searching.
we do not have any breakpoint for minocycline in Pseudomonas.
Yeah.
So we would normally not report it in Pseudomonas isolates.
Mhm.
But again, depending on the AST pattern, uh, again, depending on the AST pattern, something would be susceptible. So depending on what sample and site is it, then we would report accordingly. Maybe for crab infections, yes, we can go in for minocycline. We can go in for sulbactam-based combinations for crab. Because for crab also, sulbactam, high dose 27 gram ampicillbactam has been recommended for crab infections, which we are sending on our ASC reports.
But Dr. Sumit, is it really possible to give some 27 grams?
Not as a continuous infusion, but
No, it's
as a continuous infusion.
continuous infusion. I am not aware of Dr.
9
Prasanna.
grams ampicillbactam
Are you
continuous
using it?
infusion. Total.
Yes, sir. The 4-hourly regimen actually that we are calling to cover this 27 gram. But normally, this type of patient usually land with till that point of time when sulbactam in high dose is given. That time already AKI and all the multi-organ failure. So if you really ask me, any patient is benefited in the success story? No.
Sulbactam, you are using plain sulbactam or in combination with something?
Plain sulbactam for when 27 gram is actually we are giving.
How much gram vials are available to you?
Three.
3 means if you want to give 27.
Nine vials, yeah.
9 vials.
Nine vials we are giving like, yeah.
That is the dose we are also recommending on our AST reports for crab infections.
Okay, good. Anything more you would like to bring, Dr. Sumit?
Yeah, actually, there are certain other options also which are available. I mean, not for crab and for Pseudomonas, but we do get a very good in vitro response for chloramphenicol for CRE infections. There are many times we're getting a lot of CRE infections in blood, and for that we get a good susceptibility only and only for amikacin and for chloramphenicol, and we find them to be oxide indium positive. So these are two good options for CRE. But yes, for crab, I think the prognosis and the options are very limited, except for ampicillbactam high dose, total 27 grams of sulbactam. Pseudomonas aeruginosa, so far what we have got our experience in Mangalgiri AIIMS is that so far we found almost I won't say that pan susceptible, but yes, moderately resistant Pseudomonas. So far we have not had any pan drug resistant Pseudomonas so far.
Probably you are more new and time to come. Dr. Sarita want to
Yeah, and so
yeah, please.
So just to, I don't know because I joined in the middle of the discussion. Just to wanted to know what about the colistin if we want to target and such kind of dicey this thing scenario. Can't we shift for or prefer for polymyxin or colistin in this case, targeting both the organism if it is a susceptible one?
No, he was discussing one particular scenario where the ET aspirate showed Pseudomonas, which was susceptible only to Mero, and Acinetobacter was resistant to Mero. That is why he was.
So that's why I'm asking, what is the susceptibility for colistin or polymyxin in this case? So can't we try for that if it is a susceptible one rather than ampicillbactam? We are means we target both the organisms. So as for clinician, what is your take in that?
If coli is susceptible again, which method you are giving coli breakpoint RECs for coli? Probably polymyxin B. If not UTI, maybe tried for sure.
Okay.
Can I?
Yes, Dr. Rachna, please.
In the rounds I have been doing, my experience has been colistin if it is susceptible earlier silence. Then in cases of lung penetration is little lesser for colistin and polymyxin B. So that is the concern. So what we do is we give IV colistin. Along with that, we give inhalational polymyxin B oblique colistin. And polymyxin B has the advantage in AKI patients where the renal impairment is there, so it doesn't need renal adjustment. So I have a good experience in managing this crab infections with colistin along with inhalational IV plus inhalation colistin.
Yeah, Dr. Rachna, there will be a probability or a possibility of a webinar only focusing on colistin versus poly B. We may at some point of time think about it.
Yes, yes.
Because many patients we give sometimes empirically, blindly, even without testing it and which method, at some point we can think. If we are done, yeah.
The site of infection is really important when we plan to give colistin, because colistin has limited penetration into the lungs as well as when it's blood crossing the flow of infections is crossing the blood-brain barrier. So yet again, the site of infection is an important point to be looked into.
Perfect. Let's break for today. I thank all the panelists of today, particularly from AIIMS Rishikesh, Dr. Sarita, Dr. Sumit, Dr. Bhaskar, Dr. Rachna, and all. It was a wonderful discussion. I would have loved to take some questions from the audience. I do not know. The first thing in learning is to unlearn. If you don't ask, you go away with your same doubts. So I would request all the participants from next time onwards, please raise some questions. By that, everybody learns, even the teachers learn while answering the questions. With this remark, I would like to conclude the meeting for today. Thank you all. Thank you. Dr. Binita, you can conclude the meeting, please.
Thank you so much, sir. And thank you all the speakers for the wonderful presentations as well as discussion. And stay tuned with us for the next webinar. Thank you so much, everyone, for joining in. And thank you, Vinita, for doing the backstage work. Thank you so much. And good
Thank
evening.
you. Thank you all. Good day.
Thank you, sir.
Thank you. Thank you.
Thank you.
Thank you, sir.